Nyatwi Yesu tututu. O maudawala, tuiu, tu Yesu abetoulo. Lebedodo daji nono kalkame, tuiu, tu Yesu abetoulo. Lagbejaje nono katame, tuiu, tu Yesu apetou. Nyatepeji nono sesieme, tuiu, tu Yesu apetou. O maudo wala, tuiu, tu Yesu apetou. Senidika, inabeka, miaro, endo, miaro, ejumeidia, inabeye, miaro, endo, miaro, obreidibo, inabebo, miaro, endo, miaro. Asemi besini kwemba miara. Asemi miara. Asemi besini kwemba miara. Ejina besini kwemba miara. Obrai besini kwemba miara. Miara. Endo miara. Asemi besini kwemba miara. Asemi miara. Sina bekasini kwemba inabebo. Sina bekasini kwemba inabebo. Obrai besini kwemba miara. Enyo miara. Esromiele, miadi Yesu tututu. O maudawala, diu, di Yesu abetoulo. La medo qui bobo dai bome, diu, di Yesu apetou. Le havi subo vevieme, diu, di Yesu apetou. Le sasedam metire tome, diu, di Yesu apetou.
Fellows of the Academy, ladies and gentlemen, you are welcome to tonight's program. Shall we please stand as we welcome the chair and the speaker? And as they walk, kindly please put your phones on silence. Thank you.
President of the Ghana Academy of Arts and Sciences, past presidents of the Academy, vice presidents, fellows of the Academy, honorable ministers, members of Parliament, Your Excellencies, distinguished guests, students, ladies and gentlemen. On behalf of the President and Fellows of the Ghana Academy of Arts and Sciences, Ghana's premier learned society, I warmly welcome you all to this evening's event. It is a tradition in the Academy and in most institutions of higher learning to give their newly elected members an opportunity to deliver inaugural lectures in their areas of expertise to their colleagues and the general public. This evening, we are privileged to have a scholar speak to us on a very topical subject. The inaugural lecture used to be an in-house program of the Academy, but because of its usefulness to our friends in academia, and indeed the general public, it was made a public lecture in 1998 and has remained so since then. I would now like to introduce the chairperson for this evening's event, who will take over from me and introduce the speaker. The chairperson is Emerita Professor Isabella Kwachi, Vice President of the Sciences section of this Academy and a member of Council. She is a professor of immunology and parasitology at the University of Ghana. She is also a fellow of the African Academy of Sciences. The first emerita professor in the sciences at the University of Ghana, Professor Kwachi established the immunology unit at the Noguchi Memorial Institute for Medical Research, 1980 to 1983. She was the first female director of the University of Ghana School of Public Health and the foundation dean of the School of Public Health, which also makes her the first female dean in the College of Health Sciences at the University of Ghana. She served her term from 2002 to 2007. She is a former UNESCO Chair for Women in Science and Technology in the West Africa region. She won the 2014 Laureate African Union Kwame Nkrumah Award for Women in Science. She is the 2019 Laureate for the Clara Southmaid Ludlow Award by the American Society of Tropical Medicine and Hygiene. Women's World Day 2021 recognized her as one of 7 women in science who have changed our world for the better. Ladies and gentlemen, let's welcome our chairperson, Emerita Professor Isabella Kwachi. Thank you.
President of the Academy, Vice Presidents of the Academy, Fellows of the Academy, invited guests, students, all protocols observed, ladies and gentlemen, it gives me a great deal of pleasure to introduce our speaker for the day. And she's in the person of Professor Gladys Amponsah. Now, Professor Gladys Amponsah attended Ebri Girls Secondary School in the Eastern region. She then entered the University of Ghana to pursue a course in medicine, graduating in June 1972 with a Bachelor of Medicine, Bachelor of Surgery degree. After a year's internship, she spent another year as a medical officer in the Department of Anesthesia, Korle Bu Teaching Hospital. She received a British Council scholarship to do a postgraduate course in anesthesia at the University of Liverpool in August 1974. She obtained a fellowship of the Faculty of Anesthesia, the Royal College of Surgeons, in July 1977. The Royal College of Anesthesia has replaced the faculty. She came back to Ghana to join the Department of Anesthesia in February 1980 as a lecturer. For over 4 decades, she spent her time teaching undergraduate students, teaching and training postgraduate doctors and medical officers and research. As head of department, she put the postgraduate training in anesthesia at a new level. A number of doctors joined the department to do diploma in anesthesia program, some of whom proceeded to do the fellowship program of the West African College of Surgeons. Now, 8 fellows were produced in a period of 10 years. She was actively involved in the training of all of them, as well as being the first supervisor of the first 2 fellows. Her passion for human resource development led to her involvement in the 2 postgraduate medical colleges, the West African College of Surgeons and the Ghana College of Physicians and Surgeons. She served on the Council of the West African College of Surgeons for many years. She was the chief examiner and chairman of the Faculty of Anesthesia for 2 terms. She was the first chief examiner of the Faculty of Anesthesia at the Ghana College of Physicians and Surgeons. She joined the newly established University of Cape Coast School of Medical Sciences in November 2009. She became the Vice Dean and Acting Dean of the school before returning to Accra in November 2015 after the graduation of the first 3 batches of medical students. On the clinical practice side, she introduced some innovations, and these include the establishment of the first pre-anesthetic clinic in Ghana in June 2000, and the institution of spinal anesthesia for cesarean section at the Korle Bu Teaching Hospital, which is now practiced widely in Ghana. She put in measures to ensure perioperative pain management of patients. She led a team of anesthetists to provide anesthesia for the separation of 4 Siamese twins. The most successful was the separation of 2 female babies in May 1999, both of whom are still alive. She has published a number of peer-reviewed articles. She co-authored a textbook for perioperative nurses in 2006. She has received a number of awards and citations, and these include a citation from the Society of Anesthetists of West Africa, SAWA, for her contribution to the development of anesthesia in the West African region in 2002. She was the president of SAWA for 2 terms. She also has a meritorious award from the Ghana College of Physicians and Surgeons in recognition of her service to the Faculty of Anesthesia and Postgraduate Medical Education in Ghana in 2013. She also has a West African College of Surgeons Award in recognition of her selfless service and contribution to the growth and upliftment of the college in 2019, and a citation from the University of Cape Coast School of Medical Sciences for her enormous contribution during her tenure as Dean in 2019. Institute of Directors Ghana conferred on her an honorary award in recognition of the fantastic leadership demonstrated over many years in her field of endeavor in 2019. She has been an independent director of Intravenous Infusions PLC since July 2014, having been an alternate director from 1999. She is the chairperson of the Human Resource and Governance Committee and a member of the Technical Audit and Risk Committees. She is a fellow of the Royal College of Anaesthetists, England, fellow of the West African College of Surgeons, and a foundation fellow of the Ghana College of Physicians and Surgeons. She is a member of a number of professional associations such as the Ghana Anaesthetist Society, and was inducted into the fellowship of the Ghana Academy of Arts and Sciences in 2019. Now, audience, your speaker, Professor Gladys Amponsah. Professor Amponsah, your speaker. Thank you.
Madam Chair, fellows of the Academy, invited ladies and gentlemen. These words that I've just uttered will resonate with somebody here. And as a clinician, these are some of the words uttered by my patients. And that is why I'm here this evening to talk to you about pain, bane of mankind. So my topic is bane of mankind. And that's the outline of the lecture. We have introduction, definitions, pathophysiology of pain, assessment of pain, management of pain, experiences, that's my personal experiences in the whole process of pain management. We talk about chronic pain, palliative care, and we have to touch on euthanasia, substance abuse, and then, of course, conclusion. All living creatures feel pain. I repeat, all living creatures feel pain. And pain is experienced from the womb to the grave. Understanding of pain mechanism is still far from complete. Pain is also one of the things that bring patients or somebody to see a health worker, to see a pastor, to see a spiritualist, to see a traditional healer. So somebody may ask, why pain? Why are you so interested in pain? And the background to this interest is my training in anesthesia in the University of Liverpool. I was attached to Walton Hospital. At that time, we had one fantastic neuroanesthetist, late Dr. Samson Lipton. Dr. Samson Lipton, in addition to managing anesthesia cases, spent a lot of his time to manage patients with pain, both acute and chronic pain. I was fascinated by all these This is why, on my arrival in the country, I started thinking seriously about pain. Definition. Somebody may wonder, how do you define pain? There is an international association called IASP for short, International Association for the Study of Pain. They have defined pain after tossing it in their minds. And in 1979, the first definition of pain came out, which we all used for about 4 decades. However, there were a few problems with that definition. For example, people who cannot express themselves, like people who are unconscious or people who have cognitive problems or the newborn. And so clinicians became a bit concerned that this definition is not giving them enough tools to manage their patient. So the council of the ISP set up a committee to look at the new definition. After a lot of work, they published the preliminary results and asked people to bring in their input. Finally, a new definition of pain has come, and this is what I've got on the slide. It's any unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. So that's a new definition which they started using recently. And it took a lot of 4 decades before this new definition was made public. Now, the scientists have done the definition, but what about the clinician? I have here a slide of a lady, Mary Margot McFadden, 1938 to 2018. She was a pain nurse. And she said, okay, you scientists, you have defined your pain, but me, I'm a clinician. And so she also defined her pain, and that is, pain is whatever the patient who experiences it says it is. Are you the patient? Existing whenever he or she says it does. In other words, she is saying you cannot tell this patient that you are not in pain. No. It is what the patient says it exists. That's this beautiful lady who passed on a few years ago. The title has pain, it has got bane. So I looked up the meaning of bane in our usual Oxford Dictionary. And the first definition was a cause of great distress or annoyance. The second one, which is an old-fashioned, something especially poison, which causes death. And by this archaic definition, I'm here to tell you that pain can lead somebody to commit suicide. I say pain can lead somebody to commit suicide. Now, on this slide, I have this very important gentleman, Professor John J. Bonica, Italian by birth, migrated with his parents to the U.S. when he was young. His father died when he was only 11 years old. He had to work to survive. He had to work throughout his college life, to go to medical school, to do everything he wanted to do. In the midst of all this, he was doing wrestling. So he suffered a lot of injuries, resulting in himself the existence of chronic pain. Is it empathy at its best? He started talking to his colleagues at his university and said, we have to do something about this pain. The long and short is that he was the first to establish a multidisciplinary pain clinic in 1978. Then the IASP, which I just mentioned earlier, he also became the second president. So this is Professor John Bonica. So how do we classify pain? Pain classification is also a big problem for clinicians and scientists. I've chosen one of the simple ways of classifying pain. You can classify pain based on its origin, based on its duration, or descriptive. So the pain can come from your skin, your muscle, the superficial, or it can come from something inner, like your heart, your stomach, or your intestine. Now, when you talk about duration, how long is the pain? How long have you had the pain? And on that basis, pain can be classified as acute or chronic. And the scientists say anything beyond 3 to 6 months is chronic pain. This slide is to show you the pain pathway from the periphery to the brain. The interesting thing about this slide is that when I step on a piece of metal with my right foot, I will feel the pain on my left side of the brain. There's a crossover at a certain point before the impulses get to your brain. Theories of pain. The big scientists, they will not sleep because they know pain, bane of mankind. So they keep on working. They say, how do I teach my student what is behind pain? So they came up with so many theories, but I settled down on these two. The first one is the gate control theory by the two big men, Merzak and Wall. And the second one, which we are using currently as a model for pain management, is the biopsychosocial. You see, there are three components. There's the bio, which is the biological, there's the psychological, and there's the social. So this makes pain a very complex condition. There are things which also modify your perception of pain. And I've listed some of these things. The first one is context. And what does that mean? Like a soldier at the battlefront, he's shot by a gun. He will not lie down. He will move forward with his gun strapped on his side, chasing the enemy. He will not feel the pain. In the context, if he lies down, the enemy will capture him. He won't lie down. The culture. In our culture, men are not supposed to cry. They say, are you a woman? Oh, no, this one, there's women who do it, oh, please don't cry. They say it in the hospital. There are a lot of nurses here, so they know what I'm talking about. Or there are people who scream in the labor ward. Hey, I die, finish. That was a cultural shock when I went to the University of Liverpool, the maternity hospital, in the labor ward as appointment. I said to myself, are there no women in labor in this place? Of course there were women in labor. But it was culturally unacceptable for them to be screaming on top of their heads. The last one, catastrophizing. This thing is going to kill me. Oh, this one, dear, doctor, I won't last. So these are the way people react to pain, how they interpret pain, how they perceive pain. Pain assessment. We don't do this. Somebody has said, you have no business treating any patient pain if you have not assessed the pain. They say pain is the fifth vital sense. Are we doing it in our facilities? So how are we assessing pain? Again, a lot of work has gone, a lot of research has gone into methods of assessing pain. I settled on a few. One of the most common ones is the visual analog scale. It's a very simple way of doing this. You mark one end, no pain, the other end, extreme pain, and the patient will mark on that horizontal line where their pain lies. Believe me, the patients know exactly where their pain lies. And with this, you don't need any sophisticated equipment or gadget. I normally use a folded A4 sheet paper. That's all. Or a plastic clear ruler. That's all. You can mark one end to say, Madam, this place, no pain. That place, maximum pain. Tell me where your pain, and they will always tell you where their pain lies. This is another one that adds numbers to it. So 0 means no pain. 1 to 3 means mild pain. 4 to 6 means moderate. And after 7 is severe pain. Now these figures are important because we are told that if the pain is above 7, then you use parenteral route, preferably IV route, to give your medication, not IM. But if the pain is moderate, you can even use oral route. So these ones have clinical implication as far as our patients are concerned. Now we won't leave the children out. Warren Baker faces. Again, two great people, Warren and Baker. They worked hard. They worked hard with kids. How can we assess your pain? How can you tell me you have pain? And the result is a series of pictures. You know, children like drawing. And the picture under that slide is one of the first series of the pictures. And actually, this one was produced by some kids who were on admission. From one end, a child who is smiling broadly, no pain. On the other end, a child who is in tears, extreme pain. So on this slide, you see the modified form, where, as you can see, on my left, you see the big smile up to the right, where the child is crying. What about neonates? They were not left out in all this research. Neonatal infant pain scale has been developed. And I've experienced it with my own niece's son. Cleaning the cord with spirit, he did reflection. He withdrew his limbs, and he cried. So even the newborn baby, you can't assess pain. And in fact, most of these came from the nurses who were working with the patients, because they saw that, yes, I'm doing nursing care, TLC, but I am not managing the patient's pain. So then how do we manage pain? And I borrowed WHO's acronym. So I'm going to discuss pain management, on why do we treat pain, how do we treat pain, and the outcome of treating pain. The first bullet says that relief of pain is a human rights issue. I repeat, pain relief is a human rights issue. But on top of that, there are serious physiological consequences if the pain of the patient is not relieved, including effects on the respiratory, cardiovascular, coagulation, endocrine system. There are serious consequences. The cardiovascular, there's outpouring of catecholamines, there's tachycardia, that is increased heart rate, there's increased blood pressure, among other things. There's increased myocardial oxygen demand, which could lead to myocardial infarction. There's peripheral vasoconstriction, there's stasis of blood in the peripheral circulation, which can lead to clotting and the consequences of blood clot in your legs. Respiratory system, post-surgical pulmonary complication is a very important cause of morbidity and mortality. A patient who is in pain cannot cough sputum. A patient who is in pain cannot do incentive spirometry. A patient who is in pain cannot take in deep breath, leading to atelectasis, lung collapse, hypoxia, infection. There's also a problem with the neuroendocrine system. But after all this, the scientists are saying, and we know the long-term effect of pain. So the pain I'm talking about is not that it's just to go to Kolobu Teaching Hospital, you had your surgery, you had pain, and you went away. There are long-term consequences of not treating pain. Post-male circumcision, female genital mutilation. I picked only these two. The wanzam is on one side. But at the hospital, what were we doing? Crucifix, we tied them down. Female genital circumcision, they pinned the girl or lady down. And that physical restraint alone produces in itself psychological problem for those people. The long-term effect of this includes so many problems, including memory loss, difficulty with your relationship, and all kinds of things. Then there's also the so-called chronic pain syndrome. And I just pick on one because it's nearer to us in the hospital. Chronic post-surgical pain. This is a case where the patient wound has healed as far as the surgeon is concerned, and yet the patient complains of pain. It's something which people ignored. But now they've seen that it is real. And the incidence can be as high as over 80% in certain situations. For example, a mastectomy and straightforward herniorrhaphy. This chronic pain syndrome is high. It causes distress. They can't go back to their original work, and so on and so forth. So the wound is healed, all right. But the important thing is that this chronic post-surgical syndrome, pain syndrome, the main factor is inadequately treated acute pain. Inadequately treated acute pain. So how do we treat pain? The development of pain management has followed socio-religious culture over the millennia. In the ancient time, they thought pain was due to demons and dead spirits, among others. There was a Greek goddess called Pony, from whom we derive the word pain. She will come and punish you if you do something wrong, inflict pain on you. So ancient, in our culture, we know that people visit shrines, they play other things, animals and all, to appease the gods. There's a folklore from South Africa, Tesane Ladima, which is based on a legend that some people, if they do wrong, some of these forces will come and really show you where power lies. Now, interestingly, people also thought in the ancient time that when you have pain, they have to do something to your head. Where I'm pointing is an extraordinary bear hole. So they thought the pain resides in your head. So the best way to relieve your pain is to make holes in your head. And but they were not far from wrong, because the pain perception center is in your head. So they were not far from wrong. They were not far from the truth, rather. So that's what they call trepanation. And it was practiced all over the place, including the South American Incas and the Greeks, the Romans. They were all practicing it. Traditional healers, I remember them sitting in front of Methodist Book Depot, for example. You put the horn on your head and they suck blood. They're supposed to treat all kinds of ailments. Now, the first bullet is interesting. Electric shock from a fish. That's what the ancient Egyptians were using. The ancient Egyptians were also using herbs, poppy leaves mixed with everything. It relieved pain, it gave you euphoria, and it also put you to sleep. China has one of the longest medical history, spanning over millennia. And this symbol, I'm sure most people have seen this symbol. The yin and yang, some forces moving in your body. If there's a disruption in the normal flow, that will lead to pain. So what were they doing in the medieval times? Herbs again. They were used all over the place. They used herbs, but the poppy plant, was very popular among the various herbs that they used. Morphine, from the god of dreams, Morpheus. So no wonder when people take morphine, they go round and round in circles. Now I'm coming here to my area of specialty. Nitrous oxide was discovered in that 1772. It has got both analgesic and anesthetic properties. It has been used for such. The Liverpool technique, the so-called triad, used nitrous oxide as the only analgesic. Then somebody produced 50% oxygen in nitrous oxide called Entonox, which were used for labor analgesia and also for postoperative analgesia. Chloroform, very potent anesthetic, analgesic drug, was used on Queen Victoria for the delivery of two of her children. But it caused cardiac arrhythmias and liver damage in some patients, so it was withdrawn. Ether, another important anesthetic drug. But I put up a picture of this gentleman who incidentally was not even an anesthetist. But he took the courage to publicly demonstrate how wonderful ether was. And they were excising a jaw tumor. After that demonstration, public demonstration, somebody decided, this specialty must have a name. So again, from another Greek, we got the word anesthetis, which gave us anesthesia. So when people can pronounce our specialty, I'm not surprised, because it came from a Greek god or goddess, whoever. They say anesthesia. Actually, that's what they spell it in the olden days. Look at anesthetics. Cocaine. I say cocaine. Coca plant. Cocaine. But now we have several synthetic local anesthetics, lidocaine, pralocaine, and all the others. So cocaine is hardly used. In fact, cocaine is a banned drug in most countries. But again, I've got a picture of a man called Karl Kohler. He's a German. But he worked in Vienna with people including Sigmund Freud, of all people. And they were experimenting with portions of cola leaves. It's experimenting on themselves. Because Coca-Cola wanted anesthesia for his eye patient. Ether was terrible, they vomit. Opioid, they have respiratory depression. So what can I do to do surgery? So he and his team, the so-called Vienna group, they were experimenting, instilling coca leaves into their eyes, their mucosa, and they found that when they put it in their mouth, it becomes numb. In fact, what they didn't know was that cocaine was a very, very potent drug of addiction. Story tells us that the famous Prof became addicted to cocaine. But in the whole process, Coca-Cola discovered local anesthetic for ophthalmic surgery. Aspirin, I just rushed over this. It was a good drug for a long time, but because of problems, and that's the plant of aspirin. Paracetamol still used worldwide. Ghana is in every institution. The most commonly used analgesic for mild to moderate pain. Non-steroidal, it's got its few problems, including renal problem, GI problems. Now, morphine. Look at these beautiful flowers. Look at this beautiful flower. How on earth could you have thought that this one will lead to so many deaths? This one will lead to addiction. Beauty is vain. But morphine is a champion drug after all that. It is the gold standard against which analgesics are measured. It's widely used to treat moderate to severe pain. It's on WHO pain ladder. It's got its problems. Respiratory depression is one of the biggest problems. So is postoperative nausea and vomiting. Of course, now we have a lot of synthetic opioids, fentanyl. But look at my last bullet. Oh, sorry. I'm going first. Okay. The last bullet. Fentanyl is a drug of addiction. It is a drug of addiction, unfortunately. The number of deaths, which I'll show you in a short while, most of it is because of fentanyl. What people don't realize that fentanyl is 50 to 100 times more potent than morphine. 50 to 100 times. So what is happening in the US, they are injecting themselves with the same volume as if they are using morphine. So how do we treat pain now? Multimodal, that's the in thing, multimodal. More than one drug, using more than one route, using more than one mechanism. That is multimodal. And in so doing, it makes us use smaller quantities of each drug and so reduce the complications to be expected. We use, of course, IV opioids, non-opioids, nerve blocks, regional blocks. Now we are syringe drivers. Yes. Syringe drivers and portable devices for treating pain. But we have the drugs. We have the nurses. We have the doctors. So why do patients feel pain when they come to us? Various barriers have been identified. Healthcare workers, we are on top. Patient factors, medication, and system factors. Health workers. Pain is a necessary part of surgery. Oh, madam, but you have surgery. But why do you think you won't feel pain? It is part of your surgery. I've heard this with my own 2 years. Oh, madam, please, cool down. That's how we do it. That's how we approach pain when our patients complain. But there are also the patient factors. Some of them, I've had a patient who I was doing some work on Zomiperag, an analgesic, after hernia repair. The patient never felt pain. I asked him several times, madam, I don't have any pain. Cultural, whatever, she didn't feel. So there are patients who don't think they feel pain, so they won't request for analgesic. They are also afraid of being branded a weakling or something. And some of them are also afraid of the complication which they might have read or heard from others. Unreliable and erratic supply of medications. Now look at this one. At certain facility in a health structure, it is only tablets which are available. So if a patient goes to a facility with acute severe pain, there are no parenterals to be administered to the patient. System factors, no protocol. Pain is not considered important at all. So we talk about why we have to treat pain, because of the problem. We talk about how people treated pain from ancient time to 21st century. So what is the outcome? Why am I bothering you all this afternoon about pain management? Because there's a good outcome. To summarize it, adequate pain relief means early mobilization. Patient is out of bed, walking, coughing, no chest complication, no DVT, no pulmonary embolus. The patient goes home early to their family, to their work, and society. Now there's something developed in the UK called enhanced recovery after surgery, and in that protocol, pain relief is chief. This enhanced recovery is surrounded by pain relief from pre-induction to post-operative phase. So I'll quickly go through some of the things I have done through my years working mainly in Kolebu Teaching Hospital as far as pain relief is concerned. As I said, when I came back from Liverpool, having been trained under Dr. Samson Lipton, I was full of enthusiasm. The first thing I told my lay professor is that I want to set up a pain clinic. I didn't know what it entailed. I knew what it entailed, rather, but we didn't have the manpower to start it. Until 2017, that Kolebu Teaching Hospital started its first pain clinic. There was no proper protocol in place before I went away, no proper analgesia. So the first intervention I put in was obstetric analgesia. Pethidine was part of my management. Intraoperative, when baby comes out, postoperative, I give the IM. It goes to the stage where when the sisters saw me coming to the labor ward, they'll go for the DDA book because they know I'm going to ask for pethidine. Then we translated it to other surgeries. Patients had to bring their pethidine as part of the many things that they've been to theater. We also improved acute pain management by using gadgets. And we have here, which we still have in Kolebu, the perfuser, and this small one, which is portable, which the patient could strap on their forearm and actually mobilize. It was a joy to see these ladies, especially the gynae patients, walking about post-operatively on the ward as if nothing has happened. And you know, Ghanaians, very soon we got the news in the department that the gynae ladies have nicknamed this small device Bobokala. So there was this training also which we vigorously pursued. Diploma, membership, fellowship, which means more specialists in the department, which means that we can do more and more of pain management. So we started doing spinal anesthesia outside obstetrics. We started doing epidural, nerve blocks. Labor epidural, we could never start, and we still can't start. I've told this, the last bullet and sub-bullet, currently is still, as we started, request by staff or staff relations. And currently, it's about 4 per month. It's because it's labor intensive. We didn't leave the children out. We're doing regional block on the children, nerve blocks for hernia, blocks for circumcision in the older child. Then came another important event. With the help of one Dr. Scott from the UK, and with the permission of the Faculty of Anesthesia, West African College of Surgeons, we mounted a regional anesthesia workshop in Kolebu, based at the plastic and reconstructive unit. And this workshop, which went on for 3 years, really helped all our doctors to be confident and competent in administering regional blocks, nerve blocks, and so forth. Now, in my definition of pain, or description of I said we have acute pain. What I've said so far is about acute pain. That's the pain that you have after surgery, for example. But life is not that simple. Some people have never had surgery, but they have pain. I said some people have never had surgery, but they have pain. And usually those type of pain start slowly and becomes chronic. And by definition, chronic pain is about 3 to 6 months. There are certain things about chronic pain. You see, when you have surgery and you have pain, you know you have had surgery. But chronic pain, sometimes the cause is not known. It lasts longer. In fact, the patient may even die in pain. Management is complicated, time-consuming, can be distressful for the patient, the relatives, and for everybody. There are 2 main types. Either it's due to malignancy or non-malignant. And the non-malignant are a lot, so I'll dwell on that. Back pain. Low back pain is a big problem. Joint pains. Predisposing factors including obesity, post-surgical chronic syndrome, post-trauma, infections like herpes disease. Now, somebody has defined low back pain, which I have here, but they are using the anatomical from the costal margin up to there. That's what they define as low back. So when you have pain there, it's Now look at this figure. The prevalence, 39% from Africa, and the patients were mainly from South Africa and Nigeria. This figure is higher than the world average. And Africa, as the teacher would say, there are a lot of these heavy loads that we carry and so forth. Cost of chronic, there's a cost to this. And one author, the first bullet says, pain is expensive. Pain is expensive. Look at the figures, and this is 2010. Austria, over 10,000 euros per patient per year. This is 2016 figures. Australia, 139.3 Australian dollars. And this is 2018. But then my last bullet says, but can we really quantify chronic pain? I don't think so. It's not a question of dollars and pounds and, euros. And I put this little illustration. An athlete who wants to go to the Olympic injures himself or herself, ends up with a chronic pain, doesn't have the chance to go to the Olympics ever again. How can you quantify that kind of pain? So that's my famous Dr. Lipton, hard-working. The interesting thing about Dr. Lipton is that he himself was in chronic pain. What empathy. He himself was in chronic pain, and yet he spent his time managing people with chronic pain. So he ends up with an OB given by the Queen to people who have excelled in their various fields of endeavor. So how do we manage chronic pain? Pharmacological and non-pharmacological, or a combination of the two? And I already said pain clinic in Kolebu started September 2017, and currently have 2 pain clinic doctors, 1 nurse, and 3 senior residents. Now I'm stressing it because the American Society of Anesthesiologists has clearly stated in their document that nobody, and I mean nobody, should attempt to treat a patient with chronic pain who has not been properly trained. And in our context, you appreciate what I'm saying. You can imagine the number of quacks who want to jump in and try and tell the patient that they can do miracles and cure, when in actual fact they are going to cause more harm. So that's the American Society of Anesthesiology policy. You cannot manage chronic pain patient without proper, and they gave a criteria of what courses you are supposed to do. So the same format, history, examination, you do your investigation, then your intervention. I said that Professor Bonica he established the first multidisciplinary pain clinic. And this is being followed even up to today. So you see a whole list. Of course, anesthetist is at the top, why not? But there are all kinds of specialists who are involved. Physiotherapists, among others, nurses, trained nurses, pain nurses, acupuncturists. We had them all at the pain clinic in Liverpool. So this is a pictorial form of the non-pharmacological management of chronic pain. Psychotherapy, somebody said, psychological pain is real pain. Hydrotherapy, hypnosis, don't go there. Not everybody can practice hypnosis. And not every patient can be hypnotized. I've witnessed one. That's why I say don't go there. This is very This is transcutaneous electrical nerve stimulation, TENS for short. And this is what one of the things the ancient Egyptians were using the fish to do. This fish was giving us some electrical shocks. It's the smaller version, not the bigger one. The bigger one can kill the patient. So that formed the basis of modern day TENS. Acupuncture. For a long time, the Western world did not understand acupuncture until naloxone came. Naloxone is an antagonist to opioids. And they found out that, in fact, when they put those tiny needles into your skin at the so-called acupoints, what they are doing is releasing endogenous morphine or endorphins. That is why when we have a headache, they will put the needle at your back. Until I read this thing, I was wondering why they don't put it at an anatomical location of your pain. This is the reason. The needling releases endogenous morphine, which then goes to the circulation to heal or to treat your pain. That's acupuncture. These are other forms of non-pharmacological therapy. The pharmacological side of WHO again has come in. They originally gave us a 3-step ladder for mild, moderate, and severe pain. But because of this opioid overdose epidemic, they have put a 4th step. In other words, before you go to the step where you're going to use strong opioids, you have to do minimal intervention like epidural, injection of drugs, nerve blocks, because the way the epidemic is going is very, very frightening. Adjuvants are a very important component of treatment of chronic pain. Anticonvulsants, antidepressants, and other drugs are used. And at every ladder step of the WHO ladder, adjuvants are included. Palliative care. You cannot talk about chronic pain management without talking about palliative care. And somebody has defined palliative care. It says, a specialized medical care that focuses on providing patients relief from pain and other symptoms of a serious illness, no matter the diagnosis or stage of the disease. Palliative Care Ghana was established in August 2005. And I've been told there are 2 centers in Kumasi, Konfanochi, and Kolebu Teaching Hospital. I must say that we need to beef up palliative care because it's a very important part of managing patients with terminal diseases who usually have pain. They have other symptoms, but our focus this evening is on pain. Euthanasia. Euthanasia. A very controversial word. A word which stirs arguments. Euthanasia. Again, you cannot talk about chronic pain without talking about euthanasia. And the reason is that sometimes some of these patients are in such states of distress, of agony. So the proponents say, so are you going to continue to see your relative in that state? Of course, there will be openings, ethical, moral, religious grounds. But aside here, the population of the whole world is growing old. And studies have shown that the older you get, the more likely you will have chronic pain. And some of this may be disabling. So again, I took my Oxford dictionary, and they say euthanasia is a painless killing of a patient suffering from an incurable and painful disease or in an irreversible coma. Notice the word painless killing. Some people say mercy killing. But euthanasia is illegal in most countries of the world. There are a few countries, Europe, the Netherlands, Belgium, Luxembourg, and I think one state in the US. But most countries, it's illegal. There are different types of euthanasia. The voluntary one, where the person himself or herself is able and capable, he said, I'm tired. End it all for me. But there is no voluntary one. In that case, the patient is not in a state to give the consent. But the caregivers, the relatives, the spouse, looking on, say, my wife or my husband is in too much difficulty. I consent to euthanasia. Now I put this one, see, I put this one in red. Involuntary. What does that mean? This time around, the patient or the person is capable by saying, no, I don't want to die. But then the people around say, you will have to die. So that's why I put this one in red. The person is able, capable. They say, They say, you have to die. So that is murder. So, this is murder. It has a lot of ethical, moral, and religious implications, as it is often against the patient's will. Now, drugs that are used, anesthetists, we are in trouble. They are using our drugs to do capital punishment in the US. Now, this is from Belgium. They are using anesthesia drugs again, barbiturates and muscle relaxants. It's supposed to be painless. Painless. But all the anesthetists here will tell you that if you prioritize the patient and leave the patient to die, I wouldn't consider that as being painless. They don't like opioids because that prolongs the process and it is stressful for the nurses, for the relatives, and onlookers. Barbiturates will put you to sleep very quickly, and then they follow up with muscle relaxant to end it all. At a workshop in Legon a couple of years ago, one of the speakers also, in a similar context, said, in her tribe, they have similar thing like euthanasia. And he said, when a relation is not well and really handicapped, the elders of the family will gather and consult each other and say, oh, this one there, let's end it. And so it's very simple. They just bring a bowl of water and put it in the center of the compound. They do some incantation and all that, and the person goes. So we also have a form of euthanasia. How can I talk about medication, opioids and all, fentanyl, without devoting some time to substance abuse? Now, we don't call it drug abuse anymore. We call it substance abuse. And what is substance abuse? It's a harmful or hazardous use of psychoactive substances, including alcohol and illicit drugs, such as cannabis, cocaine, and heroin. That's substance abuse. Illicit drugs. Alcohol is also included. When you're talking about substance abuse, there are certain things you need to consider. There's something called tolerance. And what does that mean? That is when a person takes more and more of the same drug to achieve the same effect. Dependence is similar, but this one, the person has become like they are married together. And that person, if you say they should stop, they say, doctor, I will die. This is my jinkwan. That is, this is my God. I said, doctor, don't go there. This one, if you take me off, I will die. That's dependence. And they may have withdrawal symptoms, can be mild or severe. Addiction. He's taking the drug. He's having problems. But he or she can't stop taking the drugs. So some people call addiction severe substance use disorder. And it is considered a disease like malaria or typhoid. But notice that one can be tolerant and dependent without necessarily being addicted. So what are the effects of substance abuse? Negative health consequences, heavy financial burden on oneself, society, family. I know of a story where the man sold all his property, including his house. He left one room. The bed he was sleeping on, he actually sold the bed and was sleeping on the mattress. School fees are not paid. Bills are not paid. There is also the high risk of developing all kinds of disease. In fact, in the Netherlands, again, at one time they were giving, this is one of the European countries, I think Netherlands, they were giving free syringes to the drug users so that they don't exchange needles. And sometimes they end up in the psychiatric hospital. So who abuses drugs? 18 years and above, early 20s, late 20s. Children as young as 10, 12 has been seen smoking marijuana. But older generation too, we are at risk. Health workers. Health workers. And there are plenty of health workers here this evening. And this is because of accessibility and availability. So why do people abuse drug or substance? For the 18 years and all that good, they say hormonal changes. They want to show off. They want to show they have arrived. They are now men. Peer pressure, experimentation, availability, genetic factors. If there's an addiction in your family, you'll be likely to be addicted. And people have psychiatric problems. Socioeconomic problems. I just watched a video from another country in Africa, and the people said they are using those drugs of abuse because they are poor. I said because they are poor. That's why they were using those drugs. So what drugs do people abuse? I start from US again. Marijuana. I put it in red. This is followed by cocaine, methamphetamine, and alcohol. And this is a picture of marijuana. Ghana. Marijuana. We hear it in the news all the time. Interestingly, it's not only Ghana. Nigeria, South Africa, marijuana is top of the list. Relatively cheaper, easily available, people cultivate it all over the place. But my friend from Malawi told me that in her part of the world, marijuana is used like a father goes to the farm, picks a few leaves and chews it, that's all. No harm done. So, marijuana seems to be the top of the list in most countries. It's smoked normally. It is illegal in Ghana. But in the US, some of the states have legalized marijuana both for recreational use as well as medicinal use. Marijuana has got some good effect, I must say. It is a very good anti-emetic, especially on people on chemotherapy. It improves your appetite and also improves sleep. So that's what they tell us. But in Ghana, trauma. I say trauma. I've got a response. It's taking a toll on our young people. Marijuana also, some of the secondary school people put it in their shito. So your friend has shito, you are going to borrow, for Gary, be careful. Prescription abuse. Health workers, we are contributing to drug addiction. Companies, manufacturing companies are contributing to drug addiction. A few years ago, one company, I won't mention the name, was fined heavily in the US. Because of this drug. Another doctor, just a few months ago in the US, was fined $100 million for turning his patients into drug addicts. Prescription. The pain has gone and the man was still prescribing. And the patients, obedient patients, it's my doctor who, he said I should take it to, they continue to take. But there's a cost to this. Drug-associated mortality. There is a cost, unfortunately. From 2013 to 2019, the age-adjusted rate of deaths involving synthetic opioids other than methadone increased by 1,000, I didn't make a mistake. It's 1,040%. The mathematicians among us, do your calculation. 1 over 1,000%. And the next, 317 increase for psychostimulants. In 2019 in the US, there were more than 36,000 deaths. 36,000. And I've seen a sad picture on the net of a couple with their 3-4-year-old child strapped at the back in the child seat, who have injected themselves, but the two of them, dead in the vehicle. When the police arrived, this poor boy didn't know what saw happening. He was actually smiling at the police and looking into the camera. He didn't realize that both mom and dad were dead. They have injected themselves in the vehicle. The cost to society, to individuals, and to the family. Just in case we think it's all US, Ebu, we are home, Ghana. I know from our little department in Kolibu, 4 deaths, people who were in the department. The sad thing, the last 2 was when I was actually the head of department. The first one died. We buried him. We took him to his hometown. The second one, who was at the funeral of the first one, also died. And it was so pathetic. I still picture him at the wakekeeping at the canteen, the non-canteen. He was on the front row. Holding his hymn sheet. I had finished the exams in Ibadan, finished the exam in Accra. That Friday evening, I was so tired. I said, thank God the exam period is over. I'm going to rest. About 11 p.m. in the night, I heard the dogs barking. Then I heard a knock on my door, and I was called from absence. He said, a doctor from Kolibu wants to see you. I said, at this time, I'm not on duty. Anyway, it doesn't matter. I got down, and the first thing that lady said, she's not a Ghanaian, I must say. She said, Dr. Ponson, something terrible has happened to your department. I said, what? Did I hear you correctly? Or because I'm tired, I didn't hear you. I said, repeat your sentence. And she did. So I said, come and sit down. Tell me your story. She was at the door, period, tenure as head of department. So in conclusion, pain is real. Pain is experienced from the womb to the grave. Pain has been a thorn in the flesh of humanity from Garden of Eden. Pain is still poorly managed all over the place. Acute pain is best managed by using a multimodal system, which I explained earlier. Chronic pain is best managed by multidisciplinary systems or teams. Good palliative care may obviate the need for euthanasia. Substance abuse is real. Avoid it. Stay alive. Pain, bane of man. And I thank you for your attention.
We've certainly gotten a wonderful lecture of pain, the bane of mankind. Another excellent round of applause for our speaker. How can one summarize this comprehensive, diverse, and very thorough dealing of pain? I think it's touched every one of us. You know, pain is the bane of mankind. Professor Gladys Amponsah, we thank you for the exhaustive, thorough rendition of pain that touches everybody, from the womb to the grave. Now, no one escapes it. And so we have, even the definition, it defies definition, and we got the range of definitions. And there was a range of classifications, various theories, and assessment, you know, interpretation of pain, perception of pain. How do you even assess pain? And then there were issues of pain, children, neonatal, and you've got to try and assess and treat. How do you manage pain? And pain relief pain relief is a human rights issue. And then we come to chronic, you know, pain when you have surgery, but non-surgery pain, the chronic pain. And I like the fact that anything more than 3 months is chronic. So don't sit on your pain for more than 3 months and wait a year. After 3 months, seek treatment. And then the range of anesthesia, the herbals, and then we get to the hard stuff, and then treatment, adequate relief, and then the costs of pain. The costs can drown you, can drown a family to poverty. And then, of course, the Ghana Pain Clinic and all the wonderful things that are, you know, doing to relieve pain in pregnancy, in the, you know, relief of deliveries and relief in surgeries. And then, of course, palliative care. And as, you know, the aging profile, we all have ranges of pain. And we don't want to get to a place where our family would rather see us dead than maintain us or send us to euthanasia. And then the almighty substance abuse that some families are really is destroying families. And I think the take-home message is that the problems are here. It's not all the US. The substance abuse, and then the health workers, we've got to be watching out for each other. The accessibility and availability makes us very, very, you know, subject to abuse. So we've got this wonderful lecture, which I refuse to summarize, and I think we've all gotten something out of it. And we really thank you so much, Professor Gladys Amponsah, for this wonderful lecture. Thank you.
Thank you, Emerita Professor Kwachi, for those remarks. Can we give our chair a round of applause, please? Thank you. Information reaching me is that the Ghana Anesthetist Society wishes to present something to our speaker, Professor Gladys Amponsah. So, Ghana Anesthetist Society, are you here?
Good evening, and Madam Chairperson, on behalf of the Ghana Anesthetist Society, we want to present this bouquet of flowers to our mother, our tutor, our mentor. She's lectured almost all of us, and then we do this in her honor at this inaugural lecture.
Madam Chair, with your permission, the one who was speaking is the president of the society, Dr. Eric Fojo. The one holding the flower is Jonas, the secretary. The president of the society, because of this lecture, had to leave Liberia to come here. So let's begin.
Thank you, the Ghana Anesthetist Society. We have come to the end of this evening's event. And I think it is a good time to acknowledge our sponsors and the various institutions represented here this evening. Sponsors for this lecture are BD West Africa Limited, Intravenous Infusions PLC, Ghana Cocoa Board, Philips Pharmacy, Hills Pharmaceuticals Limited, Access Dental, and East Cantonments Pharmacy Limited. I'd like to thank all of them for their generous sponsorship. Now to the schools who have been with us this evening. We have the School of Anesthesia at the 37 Military Hospital. School of Anesthesia and Critical Care, Ridge. Health Concern, Ghana. Accra Academy. Ophthalmic Nursing School, Kolebu. Accra College of Education. And Peri-Operative Nursing and Critical Care School at Kolebu. Thank you all for making the time to attend this lecture with us. We are very grateful, and we look forward to having you again when we have another event here. Thank you. One of us left a small bag, outside, and it is at the front desk. If you left your bag, please ask for Deborah when you leave here. She will have it ready for you. We have a light refreshment for all of us. We've been sitting here for a few hours. Please, when you leave, make sure that you pick up a pack of food and drink on your way out. Thank you very much. If you could please stand while I lead the speaker out. Thank you.
Senyedika, hinabeka, miaro, miara, endo, miaro, miara, ejumeyedi,